Hello, I'm Dr. Omar Bey, and this is A Moment in Medicine. Our focus is health, education, and wellness. Our goal is for each and every one of us to have that opportunity to grow old in good health. Welcome to our show. As usual, I'd like to talk about caring and sharing. Remember, www.medmoments.com. That's the website that you go to and send me emails. I appreciate all the emails that have been sent so far. It gives me an understanding of what you're going through out there with your medical problems. Remember, share your med moments. Those moments that what made you realize, number one, is that I need to take better care of myself. I need to go to the doctor and see what's going on. Those med moments, share those med moments so we can help someone else improve their health. We have a great show for you tonight, an excellent show. We're going to talk about lung cancer, and I have Dr. Trevor Lane, an oncologist, to speak with us. He's going to tell us from A to Z everything we need to know about lung cancer. Dr. Lane, welcome to our show.
Thank you, Dr. Bey. Thank you for having me today.
All righty. So we're going to start.
Okay.
Very basic.
Yes.
All righty. My usual first question is, what is lung cancer?
Lung cancer essentially is cancer in the lung.
Okay.
You can have cancer anywhere. You can have cancer in your breast. You can have it in your prostate, in your colon, and lung cancer is cancer in the lung.
Okay.
We know all the risk factors, and we'll go over that, I assume, in the next couple of minutes.
All righty. I'm going to break it down just a little bit more here.
Right.
When we talk about cancer, what are we exactly talking about? Are we talking about a particular type of cell or how the cell is acting? What's happening in cancer and how it relates to the lung when it's causing a problem?
What's happened at the cellular level in cancer is that the reason why, basically, in oncogenesis, we are not all 12 feet tall and 400 pounds, is that there is a code when cells divide. When they touch each other, it's called contact inhibition. The cells stop growing. Mm-hmm. When a cell becomes cancerous, there is a DNA malformation, there is a mutation in the cell that causes the cell to just keep growing. Okay. That's what oncogenesis is. Okay. The cells just can't stop growing. They just keep growing like that.
All right. Well, you hit me with a couple big words there. Now, when you say mutation,
right.
When you say mutation, what you're meaning is that the cell is abnormal or something's abnormal with it? What are you talking about?
Yeah, it is abnormal. There is a shift in the DNA for whatever reason. For radiation, for whatever reason, there is a change in the DNA, in the structure of the DNA of the cell. Okay. That causes certain things to happen.
Okay, so DNA actually allows us to know what we're going to look like,
That's
how
correct.
tall we are,
Correct.
how you know what I mean, whether we're going to be light or dark, that type of stuff.
That's true.
But it also directs how a cell is going to be made.
Absolutely.
All right. So in cancer cells, the DNA has kind of gone a little wacky.
That's correct.
And the cells that's being made are abnormal cells.
They're abnormal cells.
In a normal organ.
In a normal organ.
And organ meaning lung.
That's correct.
Okay, I just wanted to back up on that a little bit.
That's correct. Okay.
Now, how does the patient, I understand lung cancer is a big topic and we're going to try to cover most of it.
Right.
But how do these patients present in your office? How do they come to you?
Unfortunately, most patients in my community that present with cancer present at the late stage of cancer. Most patients wait until they have symptoms, until they have shortness of breath, until they have cough, they have hemoptysis, they can't climb up the stairs, they have pain. Mm-hmm. And most times that's how the patient presents. Mm-hmm. Usually at that time, however, the cancer is usually already advanced. Mm-hmm. Unfortunately, for many years in lung cancer, there was no screening for lung cancer that was approved by a national organization. But now there is a screening process that we have in place that we can screen certain patients at higher risk for getting lung cancer. Sorry.
Okay. When you say a cancer is advanced, what do you mean by that? Do you mean that, it's in one place, or has it gone other places, or what does advanced mean as opposed to not advanced?
Well, usually advanced means it has spread to either the lymph nodes or to another organ system. Okay. For example, it started in the lung and it spreads to the brain, to the bone, to the liver, and usually at that time it is not curable, most of the time.
Now, if just the other side of that coin,
Right.
if it's not advanced, is there a chance that it could be cured at that time?
Yes, there's absolutely a chance that it could be cured. And the advancement we're talking about is the stage of the cancer. The stage 1 is the very early stage, and stage 4 is usually when it's the most advanced stage. Now, some patients with stage 1 can be cured, or stage 2 can be cured. In oncology, we measure 5-year survival. For all patients with lung cancer from stage 1 to stage 4, the 5-year survival is about 15 to 20%. But you can see when there is an early stage, for example, there is a stage 1, it is a much higher 5-year survival, like 65%. And as you go to stage 2, 3, and 4, the 5-year survival decreases.
Okay. So what we're talking about, when you say that fancy word, 5-year survival, we would say, how long am I going to live? Now, my patients come in to me and say, Doc, do I have a year? Do I have 2 years?
Right.
And that's what you're talking about.
That's exactly what I'm talking about.
And that's what you tell them, Mr.
Johnson.
Johnson,
Right.
With the type of cancer you have and where it's located, you may have 1 year to live.
That's correct. Or the data says that you have a 50% chance of being alive in the next year or 2 or 3.
Okay, all right then. And very interesting. Yeah. Now, is there a difference in lung cancer between men and women?
Yeah, absolutely. And this has been seen quite recently, where women tend to be more susceptible to the effect of smoking than men, and also they tend to present at a more advanced stage with cancer. And for 2012, the national data is that about 160,000 people are going to die from lung cancer, and it's about 80,000 for men and about 72,000 for women. So women are slowly climbing up the ladder in terms of mortality from lung cancer. Just to go back, in all solid tumors, in all cancers, the number 1 killer for both men and women is lung. The number 2 killer for women is breast. Even though breast is the most common cancer, in women it is not the number 1 killer. Lung is the number 1 killer for women. So lung cancer is a lot more aggressive, probably even more than breast cancer in women than it's supposed to be. It's a very aggressive cancer in women.
Right. Now, we're talking, you did bring up the topic of smoking.
Right.
Is it different, the amount of smoking that you do? Does that matter? Like if you have, 2 cigarettes a day or 20 cigarettes a day, does it change your chance of getting cancer?
It probably does, but I think that once you smoke, I think that 1 cigarette is probably as dangerous as 5 or 10 cigarettes a day, or a pack of cigarettes a day.
So the key is to stop smoking.
Stop smoking, period. Not 1, not 5 cigarettes. Stop smoking, period.
Now, what if I stopped smoking 10 years ago? I'm never going to get that cancer, right?
That's not true.
Oh.
Your risk of cancer slowly decreases over a period of about 15 years, but you're still at risk for lung cancer, even if you stopped smoking 10 years ago.
But does the risk decrease as the time gets
the risk
further away?
Does decrease, that's correct.
Okay.
But you still have a risk. It's not 0.
Oh, all right then. Now, what about as far as different races? Does one race tend to get lung cancer more than another race, or it really doesn't matter?
Well, I think in the African American community, the mortality seems to be higher for lung cancer because of the fact that probably people don't see their doctors as regular as in the more affluent communities. And so I think that the mortality for lung cancer in African Americans tend to be higher than in the Caucasian population. I think probably simply because of screening and simply because of the fact that the doctors are not seen as often in the African American community.
All right. Getting back to smoking, because I know it's such a big problem in this country and it's related to lung cancer directly. Right. What about this thing called secondhand smoke?
Right.
Tell me about this.
Well, secondhand smoking is if you live with someone who smokes, of course you inhale the same thing that the person who is smoking is inhaling. And cigarette smoke has about, 200 or 300 carcinogens. There are lots of things in cigarette smoke that can cause cancer.
All right, carcinogen. I just love these words. Carcinogen. Well, you got me. Okay. What is a carcinogen?
A carcinogen is a cancer-causing agent.
Okay, something like something inside that smoke or something that the smoke is made up of
Right.
that's triggering these cells to act abnormal.
That's absolutely right.
All right.
Yeah.
That's great. I like that. All righty. Well, there are other things besides smoking that I know that may cause cancer as well, lung cancer. I'm saying, like,
Right.
I know that, just to give you an example, we were when my wife and I initially went out to buy a house.
Correct.
The house had radon in it. And they had to fix that before
correct.
we could buy it.
That's correct.
Tell me about some of these things as well.
Some of those things, like radiation therapy, can cause cancer. If you have radiation, for example, for breast cancer, it can increase your risk of lung cancer. If arsenic, nickel, there are lots of hard metals that can cause, cadmium, some strange things we don't see on a regular basis, that can cause lung cancer, and is directly related to lung cancer. However, recently there have been lots of DNA malformations to certain genes that are affiliated with lung cancer that we probably may want to talk about later.
Okay, all right. Now, what about, another thing that I notice in the practice, some patients will come in their jobs.
Asbestosis.
Yeah, that there are things that they're exposed to that will cause the cancer.
Oh yeah, asbestosis is a big cause of cancer. Not just regular cancer, it causes a specific type of lung cancer called mesothelioma. And there are lots of advertisements on TV about mesothelioma, which is a very deadly cancer, and it's very rarely cured. And it's usually diagnosed very late.
Very late as well. Now, when you have cancer, what are some of the places that the cancer may go to? As far as lung cancer is concerned.
Right. As far as lung cancer is concerned, it spreads locally in the lungs, and it spreads to what's called the mediastinum, behind the heart area. It also spreads to the bone, spreads to the brain, spreads to your liver, spreads to the adrenal glands. Those are the areas that lung cancer tend to spread a lot. So.
Okay. And as you stated before, once it gets to those places, it's more difficult to get rid of it. And
absolutely.
And your life expectancy may go down.
Absolutely goes down, yes.
You got to solve this question for me.
Okay.
There's a myth out there, all right, that if you go in and have surgery for a particular cancer, that it's going to spread the cancer. Let air to that tissue and those cancer cells are going to go all over the place.
Right. That is absolutely not true. And not only for lung cancer, patients think it's the same for prostate cancer, for gastric cancer, for pancreatic cancer. That just does not happen, period.
Oh boy.
That's not how cancer spreads. It spreads hematogenously through your bloodstream or through your lymph nodes. It doesn't spread through the air. It's not an aerosolized system.
Right.
So that does not happen.
All right. So if the cancer is going to spread, what it's going to do is that a little cell is going to break off from the cancer, all right, get into the bloodstream and travel.
That's correct.
But it had nothing to do with actually the surgery. It was traveling anyway.
It was traveling anyway. Once it breaks what's called the cell basement membrane, that protective covering around the cell, it can spread anywhere in the body. That's correct.
Now, I know that there are young people that are smoking.
Yes.
Alrighty, and are they at increased risk for cancer? Do you ever see young people that have started smoking get lung cancer from the cigarettes, or
Absolutely.
is it usually an older?
No. It happens at any age. Once you smoke, I have patients that are in the late 20s and the early 30s with lung cancer.
Right.
And also, I have people, usually females, that have never smoked that have lung cancer.
Right.
They tend to have different types of lung cancer, however. Females tend to have a lung cancer that tends to grow at the edge of the lung, so it's usually diagnosed late. And the smokers tend to usually have a cancer that grows centrally in the lung, but they're also at risk for lung cancer.
Okay. Are there any types of cancers that you can have in the lung that may not be that may have nothing to do with smoking?
Absolutely. Adenocarcinoma of the lung. It has to do with smoking, but sometimes it does not. Small cell lung cancer, sometimes it's not usually 100% affiliated with smoking. And you have things like carcinoid in the lung that is not affiliated with smoking. So there are diseases in the lung, cancers in the lung that are not usually, that does not have to be affiliated with smoking. However, about 85 to 90% of lung cancers are affiliated with smoking. Oh. So the vast majority, about 90%, 85 to 90%, are directly affiliated with smoking.
Okay. Now, you broke it down to several types of cancer. Let's just go there.
Okay.
All righty. What are the main types of cancer that we will see in the lung itself?
Right. In the lung itself, there are two types of cancers. There is small cell lung cancer, and there is non-small cell lung cancer. The vast majority of cancers, about 85%, are non-small cell lung cancers, and about 15% are small cell lung cancers. And the difference is the way the cell looks. The small cell lung cancers look like small oat cells under the microscope. The non-small cell lung cancers can be divided into many types. The adenocarcinoma, which is the most common, squamous cell, bronchoalveolar carcinoma. So, and the prognosis depends not only on the type of cancer you have, and also on the stage, because if you have a limited stage small cell lung cancer, you tend to do a lot much better than if you have a limited stage non-small cell lung cancer.
Okay, we're gonna come back and just visit that a little bit better, because when you're talking about small cell, you're talking about a particular cell, how the cell looks.
That's correct.
Alrighty. Now, as far as that's concerned, basically we're talking about how treatment, it reacts to the treatment as well.
That's correct. Yes.
All right. So depending on the type of cell it is, it determines how the treatment will respond, how that patient will respond to the treatment.
That's absolutely true.
Okay. Yes. All right. When you said adeno and you said bronchial and you had a few words out there that were just flying by me here. All right. Adeno, explain that. Is that, I know it has something to do with glands. Tell me something about that.
It tends, it used to be called more of a glandular type of cancer. It's the way that the cancer cells grow. It becomes almost, it looks almost like a gland. And this tends to be the most common type of non-small cell lung cancer that we have now. It's about 35 to 50%. It depends on the data you look at.
Okay. Okay. Now, if we were to treat that, is there anything that a doctor can do that would cure a lung cancer patient?
Yes, there is. It depends on the stage. If a patient has a very early stage lung cancer, where it's, for example, a stage 1 where it's less than 3 centimeter, the patient can have...
Let's back up. All right. Less than 3 centimeters.
Yes.
So what we're talking about is a small cancer, small area of cancer, but only in one little place.
That's correct.
All right.
And it hasn't spread to the lymph nodes.
It has not gone to the lymph nodes. So it may be a little outside of the border, but it hasn't gone like to the other lung. And it hasn't gone to the lymph nodes, which are behind the heart.
That's correct.
Excellent. Okay.
And those patients can be cured. About 65% or more of them can be cured with surgery alone in some cases. In some cases, they may need radiation depending on what happens after surgery.
Okay. So what does the surgeon actually does? Does he go in and kind of hit it and say, wake up and and act right? And you guys stop producing cells like this, act right? No. Does he, tell me what he does.
But the surgeon, he can, the lungs have lobes, right? And the most common surgery he can have, depends on the size of the tumor. He can have what's called a wedge resection, where he removes it in a wedge. He can remove the lobe of the lung, or he can remove that whole side of the lung. It depends on how large that tumor is. But usually it's either a wedge resection or a lobectomy. Now there are fancy things with radiosurgery and all that stuff that's going on also. In the past, the surgeons usually would crack your chest open, but now there is VATS is done through a video screen, and they're done pretty well also. In the video assisted thoracic surgery. We should know a lot about Dr. Baby.
I know. You bring these up and then I have to explain. But basically what we're talking about is the robot.
The robot, that's correct. That's correct.
And we do a lot of surgery with robots now, and we go in, and instead of actually making the big cut and opening you up, we stick scopes in through the robot, and we can actually, through the robot, actually do the surgery.
And patients do much better because it's a much shorter healing time, and they don't bleed as much, and they do a lot better.
Okay, excellent. Now, what about as far as how do we diagnose these things?
How do we diagnose these things? Right. Initially, the most common presentation, in most patients is just shortness of breath. They don't feel well. And you'll do a chest X-ray initially. If you start basically do a chest X-ray, you see a spot in the lung. Then after that, you would do a CAT scan, and you would probably see a lot more. It would show you lymph nodes if they're involved or not. And these days we have what's called a PET scan, a PET scan, which actually would most likely tell you if those cells are cancer cells. It would light up after you have the scan done. And after that is done, then the patient is sent to the pulmonologist for bronchoscopy or to the interventional doctor for a CT-guided biopsy. It depends on where in the lung it is.
Okay.
So that's usually how we diagnose it. We start with with the chest X-ray first, and we go on from the chest X-ray to the CAT scan to the PET scan, and then we have to go at some point and get tissue. It does not matter how positive the test is. We have to get a piece of what's in there to say it's cancer.
Okay.
It has to be tested by the pathologist. They have to look at it under the microscope and tell us it is lung cancer. It could be lots of other things. It could be sarcoidosis. There could be lots of things in the lungs that look like cancer but are benign. They're not cancer.
Right.
So we have to, at some point, take a piece of that tissue and test it. Otherwise, we don't know for sure.
Okay, let's make everybody out there comfortable now.
Yes.
Let's just explain some of the procedures that you talked about, because our thoughts about it or our anxiety can make things so much worse.
Right.
And if we just have an understanding of what's going to happen
Right.
to try to diagnose it, it just makes it a whole lot better.
Right.
So you said the CAT scans, and CAT scan is just sitting in the X-ray machine
Right.
and let it click, 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 and it's just taking
That's correct.
pictures.
Yes, it is
It's
taking pictures.
Just taking pictures.
Absolutely.
Then you mentioned something called bronchoscopy.
Right.
All right. A bronchoscopy is basically, and I do those.
Right.
I understand them.
Right.
That it's a scope, and the patient is asleep. And basically, what we do is we put the bronchoscope down into the airway.
That's correct.
And see if the cancer is involving the airway, and then we'll take a little pinhead biopsy or take a brushing so that we can send that to the lab, and they can see if there are abnormal cancer cells on that specimen.
Yes.
All righty. And then you said something about CAT scan guided needle.
Right.
So you went past that one fast. Could you explain that?
Well, that is done by people that we call interventional radiologists. They're trained. They essentially would put a needle, not from the bronchoscope, but externally, sort of in your chest wall area here, and go in there through guidance and take a piece of it and test it.
Okay.
Because sometimes, if the cancer grows at the edge of the lung, and you're going Dr. Bay, it will be hard for you to get to the cancer. So they have to get to it directly from a needle or from the chest wall.
All righty. And then there's the option of surgery as well.
There's an option of surgery as well, absolutely.
Now, as far as treatment is concerned,
Right.
now, when we're talking about treatment, I know that we have several options, and
Yes.
you have mentioned several of them. Just go through, basically what some of the treatments for lung cancer are.
The early stage lung cancer is surgery, usually surgery only. And then lots of patients can be treated with radiation therapy. The early stages, the patients that have lymph nodes locally can be treated both with a combination of chemotherapy and radiation therapy. Okay. But the standard of care now for most patients that are diagnosed early would be surgery plus minus radiation. Now, unfortunately, most of the patients that are diagnosed late. So in my practice, we use lots of chemotherapy, and there are lots of good chemotherapy agents now. And just as a sidebar, the treatment for lung cancer is going, as it is with most cancers, towards targeted therapy. We do the DNA on the cells, we look for certain genetic malformations, and now we're using lots of pills instead of IV chemotherapy to treat patients with advanced lung cancer based on if they have a certain mutation in the DNA. So the treatment for lung cancer, especially advanced lung cancer, is transitioning from where we just give chemotherapy that kills all the good cells and all the bad cells, but it kills the bad cells more. And we're going towards where we're targeting that particular abnormality in the DNA that caused the cancer. Right. And those patients are living longer. And they have less side effects. They have to take a pill. They don't lose their hair. They haven't got the complications of the cancer of the chemotherapy with the nausea, the vomiting, and all that stuff. Right. So it is transitioning, it's changing.
Okay. This has been an excellent discussion about lung cancer, and I trust that you can come back and you can talk to us more about another topic, another cancer topic, because it's just so important out there for all of us to be an educated provider.
Yes.
Thank you very much.
Thank you, Dr. Bang.
All righty, all right. Well, I'd like to talk a little bit about, well, this is my Let's Talk segment. Let me just put it that way. Talk about shingles. And what we're talking about is if you have shingles, or it's called herpes zoster, basically, if you had chickenpox when you were a child, that is the same virus that causes shingles. And at an older age, basically you get a rash, or you get these little lesions or pustules either on your face or on your back or your chest or your legs. Very, very painful. And you understand that these viruses, basically, they hang out along the nerves. And when your system is down or when you get sick, they may come alive again and they may come out and they'll cause shingles. Understand that shingles, if someone's in your household that has never had chicken pox, if you get shingles, you could give them chicken pox. You won't give them shingles, you'll give them an initial dose of virus, and that will cause chicken pox. Well, in closing, and as we say in closing, well, never institute any change in your medical therapy until you consult your physician. I'm as far as what we do here and how we're doing it, I'm still so glad that each and every one of you are emailing me. Remember, www.medmoments.com, and I will be able to look at those emails and get back to you so that we can do a better job as far as this show is concerned. Until next time, I trust each and every one of you continued good health. Remember, I'm Dr. Omar Bey, and this is A Moment in Medicine. Until next time, peace to you all.